Bismillahirrahmanirrahim. Assalamu alaikum and hi my friends. As we have started the series of eye, and in this series we have reached to the chapter of conjunctiva and its different disorders. In this chapter we have started the topic of conjunctivitis. In the previous lectures we have discussed different types of bacterial conjunctivitis and viral conjunctivitis. Now we will discuss allergic type of conjunctivitis and its subtypes. Okay. So what is allergic conjunctivitis? Allergic conjunctivitis, it is the allergic inflammation of the conjunctiva due to environmental allergens, which is characterized by redness and watery discharge. Okay. So redness and watery discharge due to environmental allergen, it is called allergic conjunctivitis. The subtypes, the first one is acute allergic conjunctivitis. So the etiology and clinical features are that acute allergic conjunctivitis, it is basically type 1 hypersensitivity reaction. And we have the basic knowledge of type 1 hypersensitivity reaction. That what is it? I will give you a short overview. Okay. So when a body is exposed to an allergen, what is happening? The white blood cell like T cell will encounter the allergen and it will carry this allergen to the lymph nodes. And the lymph nodes, the T cells will differentiate into different types of cells and it will generate antibodies. Okay. And these antibodies will then come and will attach on the surface of mast cells. When a person is exposed again to the same allergen, what will happen? This allergen will come and this will react with the immunoglobulin antibody already on the surface of mast cell, and this attachment will initiate a reaction inside the mast cell, in which the mast cell will degranulate and will release different types of inflammatory mediators which will cause the inflammation. Okay, so this is a short overview of type 1 hypersensitivity reaction. And this type of allergy is mostly it is presented in young children and adults. Okay, and it is during this most commonly during the spring and summer. So when a child or young adult, when they are playing and they present to you with in the spring, when they present to you with redness of eye, watery discharge and itching, it is most probably the acute allergic conjunctivitis. Okay, remember that the itching and the chemosis. Chemosis is when there is the inflammation. What will happen? The inflammation will also cause the edema of the conjunctiva. So the conjunctiva will edematous, like in this region it will edematous. So the edema will bulge the conjunctiva outward. So this bulging of conjunctiva due to edema, this is called chemosis. Actually, in simple word, the chemosis is actually what? It is edema of the conjunctiva. Okay. So chemosis, this edema and itching, these are the hallmarks of acute allergic conjunctivitis. So treatment. The treatment options, they are simple. So apply the cold compression. Okay. When we apply the cold compression on this allergic eye, it will reduce the inflammation and redness, edema, etc. We can also use antihistamines, which is, for example, imidazole and epinestins. These will also reduce the itching and inflammation. We can also use mast cell stabilizer, as the mast cells are also mainly involved in this type of allergy. So when we stabilize the mast cells, the mediator will not be released and hence the reaction will not occur. So mast cell stabilizer can also be used. Okay. Now the second one is the seasonal and perennial allergic conjunctivitis. Seasonal and perennial allergic conjunctivitis, it is also the allergic inflammation of the conjunctiva, but it is non-specific. But the allergen in this case, they are non-specific, and these reactions and these allergic reactions can be acute or subacute. Okay, the acute allergic is acute, as from the name it is apparent that it is acute. But the seasonal and perennial, they may be subacute or acute, and the allergen in this case, they are non-specific. Okay, so and this is also type 1 hypersensitivity reaction, as we discussed in acute allergic. So what is the differences between the seasonal and perennial allergic conjunctivitis? Seasonal allergic conjunctivitis, it is the most common form of ocular allergies all over the ocular allergies. The most common form is the seasonal conjunctivitis. Okay, it is most commonly associated with runny nose, rhinitis. Okay, and it is also occurring most commonly in the spring and summer. And the last, the allergen in this case, they are mostly pollens. Okay. On the other hand, the perennial allergic conjunctivitis, it is less common, it is less severe, and it occurs throughout the year. Yes, the seasonal occur only in spring and summer, but the perennial occur throughout the year. Okay, and the allergens in this case, they are mostly animal danders, house dust, etc. Okay. So the treatment option for seasonal and perennial allergic conjunctivitis, they are similar. For example, like this: food compression, antihistamines, mast cell stabilizer. If the case is severe, we can also prescribe steroids. Okay. The patient will present as with red watery eye. When the patient present with you with red watery eyes and with runny nose, it is most probably seasonal and perennial type of allergic conjunctivitis. Okay, most commonly seasonal. The third one is vernal keratoconjunctivitis. So what is vernal keratoconjunctivitis? Vernal keratoconjunctivitis is a bilateral allergic inflammation of the conjunctiva, and it is recurrent. So recurrent bilateral allergic inflammation of the conjunctiva is called vernal keratoconjunctivitis. Etiology and epidemiology. It has both type of hypersensitivity reactions, type 1 as well as type 4. For type 4 hypersensitivity reaction, we have the basic knowledge of these type of reactions, so we will not go into the details of these reactions. Okay, so it involves type 1 and type 4 hypersensitivity reaction. The patient in this case, they are mostly from 5 to 15 years old and most common in boys. So from 5 to 15 years old, mostly boys, and this patient will have the history of atopy. What is atopy? Atopy is the predisposition to allergy. Okay, predisposition to what? To hypersensitivity reaction. This is called atopy. So when these kind of patient, the vernal keratoconjunctivitis patient present to you, they will from the age 5 to 15-year-old boys, and they will have about 75% of the patient will have the history of atopy. That there is the family history of atopy, so it will make us easily to diagnose the condition. Okay, these type of epidemiologies, if we have in the mind, it will make us the diagnosis easily. Okay. Now, vernal keratoconjunctivitis it is presented also like these type of allergies mostly in the spring and summer, and it occurs in three forms. So there are three subtypes of vernal keratoconjunctivitis. The first one is the palpebral form, the limbal form, and the mixed form. It has the features of both. Okay. So what is happening in the palpebral form? In palpebral form, what is happening? It will have the features of it will have the characteristics in the palpebral conjunctiva. Okay. We know that we have discussed previously that in allergic type of conjunctivitis, we have papillary type of reaction. Okay. So it will have papillae. When we take a look through the when we lift the conjunctiva, most commonly the upper tarsal conjunctiva, it will have papillae, and the papillae will enlarge so much. There will be so much hypertrophy of the papillae that the appearance of the upper tarsal conjunctiva will become cobblestones like appearance, which is also called pavement stones. So cobblestones or pavement stones appearance will be present on the upper tarsal conjunctiva. For example, this is. So the papillae will so much enlarge that it will induce the cobblestone or pavement stone appearance. Okay, if the case is severe and it is not managed timely, then these papillae can become giant papillae, and which the papillae will look like the excrescence of cauliflower. Okay, so it will look like the excrescence of cauliflower, and this is called giant papillae. Okay, it can grow up to so much that it can cause ptosis. So in the palpebral palm, when we look through the upper tarsal conjunctiva, most commonly through the upper tarsal conjunctiva, it will have cobblestone or pavement stone appearance, it will have giant papillae, and it will have rupy mucoid secretion. As I told you, the condition is recurrent, so it becomes chronic. And in chronic allergic conjunctivitis, we have mucoid secretions. So there will be mucoid secretion, okay? In between them, we will have sticky mucoid secretion, okay? Like rupy. Rupy mucoid secretion will be present. This is the limbal form of vernal keratoconjunctivitis. Now, what are the features in the limbal form? Limbal form means it has mainly involved the limbal conjunctiva. So, there will be papillae on the limbus, okay? So, the papillae are now present on the limbus. These papillae will look like gel. So, that's why they are called gelatinous papillae. Okay, so in limbal palm we will have gelatinous papillae, and on the gelatinous papillae we also will have some superficial white spots, like I will make it on red, okay? So we will have superficial white spot like this, and these superficial white spots, they are called Trantus spots. These are actually made of, for example, if this is papillae, okay, if this is papillae, papillary reaction and papillae, so the mast cell, this is the apex of papillae. So what will happen? The eosinophiles will accumulate the apexes of papillae, okay? So the papillae will be surrounded, its apexes will be surrounded by eosinophiles, and this will make white superficial appearance. This whitest superficial spots in appearance, this is called Trantus spots. So in the limbal form, we will have gelatinous papillae and Trantus spots. Okay. Now in the mixed form, we will have the characteristics of both types of conjunctivitis, the palpebral form and the limbal form. But remember, the problem to the cornea, it will be more in palpebral form. Why? Because we have the cobblestones and we have the giant papillae. So we will open the eyes and close the eye. So the cornea, these papillae will rub against the cornea, and it will cause more damage to the cornea. So that's why the palpebral palm has keratopathies. The keratopathies are, for example, there will be punctate epithelial keratitis, okay? The punctate epithelial keratitis will be present, and it may cause micro erosion of the corneal epithelium. So there may be the micro erosion, okay, of the corneal epithelium, and this micro erosion can advance to the macro erosion. So okay, micro erosion can advance to macro erosion, and when these macro erosion of corneal epithelium, when it is covered by the mucus, okay, when it is covered by the mucus, now this macro erosion has created ulcers, okay. So when the corneal epithelium has detached, so it will become ulcer. So when these ulcers, these macro erosion ulcer, when they are covered by desiccated mucus, it will be called shield ulcer, because the ulcer has been shielded by the desiccated mucus. The dry mucus, the desiccated mucus will come and it will cover the macro erosion in ulcer. So these are called shield ulcer. So the keratopathies are punctate epithelial keratitis, micro erosion of the corneal epithelium, macro erosion of the corneal epithelium, and shield ulcer, in which the desiccated and the dry mucus come and cover the macro erosion areas. Okay, and these keratopathies, these are most commonly encountered in palpebral form of vernal keratoconjunctivitis. Okay, so these were the clinical features in the palpebral palm, limbal palm, and mixed form. Now, what are the treatment options for the vernal keratoconjunctivitis? The treatment options are like in these allergies, we can give cool compression to reduce the inflammation, redness. We can give antihistamines like imidazole, epinephrine. We can also give mast cell stabilizers, okay, like sodium chromoglycate and lidoxamide. we can get the combination of both, and antihistamines and mast cells. Okay, so the combination of antihistamine and mast cells such as azilastine, and ketotifen, these can be given. Okay, and they will have more beneficial effect because this azilastine and ketotifen, they contain both antihistamine and mast cell stabilizer. Okay, and so NSAIDs can also be given. Non-steroidal anti-inflammatory drugs can also be given, and it will give to more comfort to the patient. Why? Because it will also block the non-histaminic mediators, and it will give more comfort to the patient. We can use steroids, but steroid cannot be used in long course. Why? Because we know that steroids causes the complication like the glaucoma and cataract. So when we use steroids for a long duration of time, it will cause complication. That's why we do not use steroids in long course. Okay? If the condition is not managed, if the vernal keratoconjunctivitis is not managed by cool compression, by antihistamine, mast cell stabilizer, steroids, and NSAIDs, then we will use immunomodulators. Immunosuppressants such as cyclosporine can be used, calcineurin inhibitor can be used, methotrexate can be used. Okay, so these can be used. These immunomodulator and immunosuppressor can be used if these all topical medication does not control the condition. In topical medication, the last resort is the suprasteroid injection. So we will inject steroid in the supratarsal region. Okay, so in the supratarsal region we will inject the steroids. For example, the triamcinolone, the prednisolone can be injected in the supratarsal region, and this steroid can give us the treatment. Okay, but remember, if these all topical medication failed, they failed and they didn't control the vernal keratoconjunctivitis, then we will go to the systemic therapy. In systemic therapy, we will get the patient oral histamine, oral immunosuppressants such as cyclosporine, methotrexate, etc. So, if this topical medication fails, then we will give systemic therapy to the patient of vernal keratoconjunctivitis.